Well, folks, welcome to our chapter 27 of the Bouncebacks Critical Care book, and this is Monday, May 5th. We have a fantastic panel, and we have an interesting case. And the case is interesting because a little bit of a spoiler alert is there was some iatrogenic harm that was caused. Now, not throwing shade at the folks who did this management, because this is something that can happen. But hopefully, as a result of learning about this case and from the insights from the panel here too, we're going to be able to, next time we have a patient like this, hopefully prevent that from happening. So I want to start sharing the screen here, and I'm going to also introduce our fantastic panel for today. So the first thing, and most importantly, is there are no folks who have any type of disclaimers. I'm not really sure how you would have anything that would be a type of conflict of interest with this type of situation. However, just in case there could have been something, that is not something that's happening. The CME will be awarded. Everyone gets an hour of free CME. And here is a QR code. We will flash this up later towards the end of the program also. And also want to make folks aware that we're really happy to have questions that you want to put into the chat, and we will monitor that as we go through. It might not be as timely as you'd like, but it will definitely be monitored. So the folks we have here are Mac Brown, who I was actually just with at the UCA conference in Dallas a few weeks ago, and then a few weeks before that when I was down doing grand rounds for JPS. So Mac, great to have you as a part. Mac is an attending emergency physician and also a MedEd fellow, which is fantastic, working with Jess Mason. Dan Kernan is one of the senior family medicine residents at Adena Medical Center, where I work, and he's going to share his insight because there's obviously a lot of emergency medicine and critical care that we've been talking about, but in addition to that, there are some primary care aspects that relate to this also. Karina Reyner, who now we do have as part of things, so Karina, thank you for the patience in joining, Associate Professor of Medicine, Texas A&M in Dallas, and Department of Emergency Medicine, Baylor, and then also Joe Shiber, who we had on our last month's Bouncebacks. And Joe, honored to have you back. We certainly enjoyed having you here, and your insight was invaluable. Professor of Emergency Medicine, Neurology, Surgery, and he is at the well, I'll let everyone read the initials there, but in Jacksonville, Florida. So Joe, super glad to have you as a part of this. So we'll start with our actual case here, and sometimes we go straight to that bounce back visit, but for this one, we're going to start off talking about the initial visit, and then we'll talk about the 3 different decision points when the patient does bounce back. So this is a 55-year-old man with elevated blood pressure, and I'll just summarize the record. This is the actual documentation. Nothing has been changed for HIPAA. This is a 53-year-old gentleman, no documented past medical history, who presents a complaint of high blood pressure. We've all seen this patient before, and I have to say, in a little bit of a self-deprecating way, is this is a patient that, especially early in my career, I mean, I think every patient that I had with a asymptomatic elevated blood pressure, I got a patient complaint on, because I just probably didn't acknowledge their concern, because in the end, of course, high blood pressure is important to treat, obviously more for the long term, but that asymptomatic part of it was the thing that sort of got me. So I've learned from my mistakes, and hopefully we'll all be able to, with some of the knowledge from this case, again, be able to provide best care. So at any rate, he checked his blood pressure from local pharmacy. The cuff said over 200, and he denies specifically chest pain, shortness of breath, visible changes, headaches. So obviously, this emergency physician was looking for signs of end organ damage, looking for a hypertensive emergency. He has no significant past medical history, really, based on the record here. Doesn't take any medications, and he does have a blood pressure of 202 over 135. So, you know, I think we're all probably thinking, you know, is this the first time this really happened or not? Hard to say. But at any rate, they do an exam, which seems like a pretty good exam. The vital signs are not rechecked again, although they do say that he had an EKG that showed normal sinus rhythm with a rate of 80. They say in the medical decision-making note, patient presents with asymptomatic hypertension, sort of an interesting terminology, but again, I get it, and I'm sure I've used those words too. No evidence of hypertensive emergency, no chest pain, shortness of breath, neurologic deficit. And this is also interesting. Per ACEP guidelines, no indication for further testing. We'll talk a little bit about quoting guidelines in a little bit. I'm not saying it's a bad idea. I'm just saying we should have some caution when we do it. Follow up PCP, diagnosed hypertension, follow up in 2 to 3 days. So we're going to start out before the bounce back visit. We're going to start off with a question for Dan. And again, Dan, and your primary care expertise, what are some of the official guidelines as far as the diagnosis of hypertension? And what would you think about if you saw a patient in a primary care office with a newly elevated blood pressure? If you did want to start that patient on medications, what would be maybe a couple first-line choices you would use?
Yeah, so really common scenario, of course, that we see in the primary care office, following up from the emergency department, situations like this where, a patient goes to the pharmacy, gets their blood pressure checked, and it's something crazy. They go to the emergency room and they tell them to follow up with their PCP. So one of the big guidelines that I look at is in 2020, the International Society of Hypertension came out with guidelines recommending to make the threshold for diagnosing hypertension 140/90 with multiple readings and in the office, or a little bit lower, 135/85 if they're taking readings at home. And then per the most recent Joint National Committee guidelines, as far as starting pharmacological therapy, that threshold is 150/90 for adults older than 60. And then the cutoff is a little bit lower for those younger than 60, 140/90, and then that's the cutoff for diabetics as well, across all age groups. As far as initial therapy, usually ACEs or ARBs are usually what I go to first line, pending specific cases, can do thiazide diuretics, calcium channel blockers, especially with the Black population. Typically thiazide diuretics and calcium channel blockers would be first line, and then we'll reevaluate them in 1 month to see how they're tolerating that.
Awesome. Perfect. So, Karina, I am sure exactly like you and all of us on the call have so many patients that come in with a blood pressure which is crazy high, and you recheck it and it's like 120/80. Now, it's not always normal when you recheck it, but sometimes, that stress maybe of going into the emergency department, or the lights and sirens, or maybe a blood pressure cuff that is the incorrect size blood pressure cuff, right? You have this crazy high initial blood pressure. When we do have a patient with elevated blood pressure who's maybe coming in for an unassociated problem, or maybe they're coming in because they checked at a pharmacy and it was high, what are the chances that they'll eventually be diagnosed with hypertension, and what are some of the ways that we really know that was an accurately taken blood pressure?
I think that's a really good question, and something that we commonly encounter in the emergency department. So if a patient presents with elevated blood pressure in the ER, it's not always just a stress response, as you mentioned, or white coat hypertension like we're taught. The chances that they actually are eventually diagnosed with hypertension is actually pretty high. And we actually have some data that's looked at this question. So there was a 2017 study in the Annals of Emergency Medicine that found that among patients with no prior history of hypertension, with an ED blood pressure of 160/100 or higher, about 26% of those patients were eventually diagnosed with chronic hypertension or started on some sort of pharmacological therapy within 2 years. And there's some broader research that supports this as well. We have systematic reviews that have found between 30 and 50% of patients with elevated blood pressure are later confirmed to have hypertension. So I think that, like every vital signs should be trended in the emergency department. Making sure that your cuff is the appropriate size is obviously a great first step, but I think it's important to have 2 points on a curve. And, if a patient presents with a complaint that's pertinent to their vital signs, like an elevated blood pressure, then it's really the onus is on us to do subsequent blood pressure readings while they're in the emergency department, just to identify a trend, either a reassuring trend for discharge, or maybe, if their pressure goes from 160/90 to 260/100, then maybe our management's going to look a little bit different.
Yeah, and I love that, because in the end, look, we probably all have forgotten the blood pressure of 160/100, and the patient's there for ureteral colic or some other like unassociated complaint. But this patient actually did present for his elevated blood pressure.
Right.
So, Mac, they did quote the ASAP guidelines. So, first of all, I'd be interested to have you summarize what the ASAP guidelines actually say or show, and then what your thoughts are on just quoting the guidelines as opposed to quoting the specific thing that the guideline says.
Okay, I started talking immediately and the mute was still on. So It's kind of interesting because they ACEP just redid their guidelines for asymptomatic hypertension on the 22nd of January of this year. And it's always level C evidence because, you know, they don't have any large grand scale papers that they can compare with. But the new consensus is saying that you can start antihypertensives from the emergency department and discharge them with that. Because, you know, there's a lot of factors there that a lot of beneficence there. And very rarely are there any actual harm that these are causing that they've been finding in the one study that they found was pretty large. In the past, I know it would say you don't have to, it's better not to. But now the data is kind of supporting a little bit of a shift in change in practice there. So that was kind of interesting.
Yeah, and I think, in all fairness to this clinician, right, when this patient was seen several years ago, the previous guidelines were a little bit, you know, more on the other side, just like you're saying. So let me ask you, and maybe even interesting to the whole panel here, you know, I've frequently had this question when I, you know, do different lectures, and I'll saying something like, can I just say PERC negative, you know, for the pulmonary embolism rule out criteria rule? And I then will ask, would you feel comfortable standing up in this room of your peers and telling us all the PERC criteria? And I've never had someone answer yes to that. Now, again, maybe we know them or pretty close to it. But even when one time I heard Jeff Klein interviewed, and he said, you know, when they tried to do it, you know, is it over 100 or 100? And when they just changed it to even that 1 point of, or 1 beat per minute, then the rule did not work anymore in that sort of way. So, you know, to me, it always feels like if you're doing something like the Thompson test, like an Achilles tendon rupture, instead of saying positive or negative, it's like positive when you do have plantar flexion or positive when you don't have plantar flexion, right? Maybe it's better just to say what your test showed in the same way when you have only one blood pressure reading, and this is a pretty high diastolic. I mean, I'm a minimizer when it comes to elevated blood pressures, but, you know, it is definitely on the higher side. So maybe it'd be nice to say, you know, per the ACEP guidelines, which say this, that, whatever, you know, or I discuss with the patient starting medication, he'd prefer to wait 2 days. And to me, it feels like it'd certainly be safe to wait a couple of days to get that patient started something. So, Joe, can you wrap this all in a bow for us before we get to the bounce back visit? How do you think the care or even the documentation at this initial visit could have been improved?
So this is, you know, a visit in ED is a snapshot. I always try to, you know, when I teach the residents, it's better to make it into a slideshow or a film than a snapshot. So you need multiple points in time. Remember, vital signs can never be stable with one set. Stability means over time that they're not changing abruptly. So at least another set, I think, of blood pressure. And the point I made in the editorial part of this was that he doesn't have symptoms, but at that blood pressure, 202 or 135, that is a map of about 155, 160. That already is about at the limit of cerebral autoregulation. So he will have symptoms. That's the point. That's like saying your heart rate could be 150 and, you know, it's a young person and they feel okay. Yeah, but no one can go okay with the heart rate of 150 or ongoing. So you would never discharge someone with a heart rate of 150, even though they're 18 years old. So this is a blood pressure that actually is what I would call this would be a hypertensive urgency. It may not be an emergency because there's no end organ damage right now, but it will be. So something more needs to be done. The comment that you made earlier, Mike, about you know, sometimes feeling the pressure to do things when there's nothing really to be done. The example I try to give to the patients is smoking, obesity, sedentary lifestyle. None of those things are good, and we would never call those normal, but I can't have an intervention now to fix that. So a blood pressure that's not normal, but again, not an emergency right now, I'm not condoning it, but there's nothing that physically I can give you as a treatment that's going to make you better. It's something that you're going to need to adapt your lifestyle going forward with a PMD. So sometimes that phrase, I think, helps residents when they feel like they need to do something on the spot, when in reality they don't. They do need to address that it's abnormal. And the last thing, remember, non-invasive blood pressures, unless you're doing it manually, are oscillometry, which does measure a map, and then it actually has an algorithm that extrapolates the systolic and systolic and diastolic. So those pressures may change from reading to reading, and so you really do need to get a few of them in a row before you feel comfortable that that the systolic and diastolic are actually relatively accurate, even with a good fitting cuff.
Yeah, and probably this guy's had a blood pressure high. I mean, we could guess for quite a long time, unless he just happened to develop a pheochromocytoma like the day before.
He had
Now,
to have, because people don't tolerate pressures that high. They really had to have shifted their entire vasculature, not just cerebral, to be tolerating it. And the one thing in the exam that I know is inaccurate is that he would have an S4. They say no murmurs, rubs, or gallops. He would have an S4 with the blood pressure that high. So it makes me think that maybe they didn't actually do the exam, or they went through it so quickly, because there's no doubt that he would have an S4 with an elevated blood pressure of that range.
Macros can be a blessing and a curse, without a doubt. And I just wanted to call out Curtis Mays on the chat says, the recent AHA statement and article in JAMA on asymptomatic hypertension. So Curtis, I'm guessing that you're talking about the article by Anderson et al. And if that's the one you're talking about, we are going to discuss that in a little bit, because that feels like a game changer article. If it was a different article, love to have you put the citation in the chat there. But if that's the case, we are going to talk about that. So what happens with this patient? Well, they get sent home, and then as it turns out, this patient 1 day later comes in seizing. Okay, so I'll just briefly summarize the presentation. Brought up by ambulance with seizures, but no known history of seizures. Per his wife, been complaining of a headache with nausea and vomiting. So maybe a little bit to the point, Joe, that you were talking about. You can't really go along with a map of 155, 160 for too long, right? With vomiting since shortly after discharge, was found seizing prior to arrival, given 2 of lorazepam, and I'd be interested for people's thoughts along the way, what they think about that dose. But, you know, maybe that was an adequate first dose, right? His blood pressure now, if you thought the first one was impressive, 224 over 140, acutely ill, afebrile. The good thing, his head is still normal, cephalic and asymptomatic. But at any rate, his pupils are sluggish, he's tachycardic, and they say headache or seizures, hypertension, recent complaint of headache, presumed subarachnoid hemorrhage will control the seizure activity and proceed immediately to the CT scan. So Dan, let's start with you again on this. And with every patient, we need a differential diagnosis, right? So what would be your differential on this patient at the time who has not only high blood pressure now, but high blood pressure and seizures?
Yeah, so in this guy presenting with hypertension and seizures, we'd of course be suspicious for subarachnoid hemorrhage. Also hypertensive emergencies like intraparenchymal hemorrhage or PRESS. Also would want to consider metabolic causes like hypoglycemia, uremic encephalopathy, drug intoxication or withdrawal, especially alcohol, structural causes, intracranial mass, I believe is one listed on there. And then infections causes, of course, meningitis, encephalitis. I also think it would be beneficial if a family member or somebody was present. You can ask him if he does have a seizure history, ask him about, things like alcohol, other drug use, if he recently, stopped drinking alcohol and might be going through withdrawals or something like that.
And I think that could be one of our real big first teaching points is the follow-up question. Now, of course, we're not asking this patient because he's seizing, right? But if there's family there, saying something like, not for him, but, do you use IV drugs? Now, when was last, have you ever used? Yes. When it was? A long time ago. When was that? Again, many follow-up questions sometimes. Well, it's 3 days ago. Well, 3 days in a patient who uses IV drugs and is withdrawing, that is a really long time ago. In the same way, it might not be that he's using substances or alcohol, but stopped using those substances, whether it happened to be alcohol or maybe benzos, something like that, right? So he's seizing MAC, and I think I know the answer to the question I'm about to ask you next, but we need to make a diagnosis, but he's also currently having symptoms. How do you balance the management of that patient acutely with the need to make a definitive diagnosis as to what's going on with them? What do you do first?
Well, I try and take as much information as I can in. There's a great little phrase. It's like, you don't want to gamble anywhere besides Vegas kind of thing. I definitely don't want to gamble on a patient in a gurney. You have to treat the seizures, of course, but you can also diagnose a seizure, hopefully be able to diagnose a seizure just with your eyeballs. So treating that, trying to figure out, is it hypoglycemic induced? Is it, alcohol withdrawal? Is he having some kind of weird, meningitis? And he's already hypertensive, and the meningitis is causing him pain, making him more hypertensive. And that's the kind of piece here is you can diagnose the seizure, you treat the seizure, but you have to get more testing and other things involved before you start making the diagnosis elsewhere. Because if he's hyponatremic, you're not treating the blood pressure is not going to do anything. And that's kind of the big monkey wrench here is his blood pressure is really high. But if he's hypoglycemic, blood pressure management is not going to do anything, right? If he's having a big subarachnoid or if he's having a massive ischemic stroke, blood pressure range is also difference between them. If he was a pregnant woman, massively different blood pressure range. So all those little pieces matter, and diagnostically, you have to figure out where you're going before you start traveling. You know, if I want to get a burger, I'm not just going to start driving on the road. I'm going to find a Whataburger. You know, I'm in Texas, you know, yeehaw. And then I would go to a Whataburger. I wouldn't just start roaming around.
You know, I like that you said that you shouldn't gamble except if you're in Vegas. And just 2 days ago at that conference that I was with you at in Dallas, I used the phrase that I heard from Greg Henry, actually, is that there are old pilots and there are bold pilots, but there are no old, bold pilots. And yeah, you know, if you gamble frequently, at some point, even if you're 99% right, you're going to come up with that 1%, right?
Yep.
So, Karina, I'm going to put you at the bedside. I'm going to put you in the footsteps. And I know you thought it was your night off, but it is not. You are actually now in a white coat and working. You got this guy, paramedics bring the patient in. You got all the history you can from the paramedics. And we talked about what the wife had to say. And you know that the patient had received 2 milligrams of Ativan prior to arrival. What are you going to specifically do? Specifically, how long are you going to wait to see if there's a response? If there's not a response, what are you going to do regarding this patient who is now still seizing?
Yeah, I think one of the things you're always doing as an emergency room physician is you're sort of doing things simultaneously, right? And so management here is going to involve several steps all at once. The thing that I noticed about the patient, the vital signs, is that he's bradypneic. His respiratory rate was 8. So I'm already thinking airway as I'm sort of having my nursing staff draw up more lorazepam. So, you know, ensuring that the airway ABC, start off with airway breathing circulation, providing oxygen via non-rebreather and nasal cannula. And if I have IV access, which it sounds like we have in this patient, then I'm going to be calling for 0.1 milligrams per kilogram of lorazepam with a dose of 4 milligrams. And if the patient doesn't stop seizing within a few minutes of them giving the last dose, then I'm going to be administering the second dose of lorazepam. And then, of course, you know, if you don't have IV access, I would start off with intramuscular midazolam. That's a good option. And you can go up to 10 milligrams for that. You can repeat the dose, especially if the seizure continues. And then next up, you know, if the seizure hasn't stopped, then you're really looking for your second line anti-epileptics. And you can use either Keppra, you can use valproic acid or phosphonatoin. We have some good data that came out of the ESET trial that showed that those medications are all equivalent in different doses. So for Keppra, you want to use 60 per kilo. Valproic acid is going to be about 40 per kilo. And then phosphonatoin, your 20 mg phosphonatoin equivalents per kilogram. And then, of course, if you're still having refractory seizures despite your second line therapy, then you're going to be considering sort of more aggressive therapy or IV anesthetic agents like propofol and pentobarb. But hopefully the patient responds to some of those first line agents.
So Joe, Karina just talked about the patient who had a respiratory rate of 8 with only 2 of Ativan, probably wasn't from the Ativan. And, you know, obviously, I would say obviously, but I think a lot of people are reluctant in some ways to give too much, but you don't want to give too little either. So it looks to me like we're sort of heading down the road towards intubation. So give us some, from your critical care expertise, obviously, a patient with recalcitrant status epilepticus requiring intubation, which medicine would you use for this patient? Or would you just do the typical, I mean, I don't know if you're still using etomidate and rock or whatever you're using, but would you do something differently based on the fact that the patient is seizing?
Okay, so the 2 questions, I'll answer them in reverse order. When do you intubate? You intubate when either gas exchange is inadequate or airway protection is inadequate. And the third reason is even when you think they're either those are still fine, but you're now going into the third tier of treatment where you actually are going to be doing anesthetic doses, and whether that is propofol, you know, phenobarbital, you know, ketamine is the only thing that actually is an add-on. You don't necessarily have to get airway control of, but the others you would. So sometimes even when they're breathing and airway is adequate, but it is simply for the fact that you have to step up the intensity of your treatment for the status epilepticus, you actually need to intubate. This patient is concerning because, yeah, the respiratory rate's low. Usually when you see someone with that extreme of a blood pressure and they have and the respiratory rate may not be low because of the Ativan, it may be low already because of brain dysfunction. Oftentimes they have bradycardia because actually as a response the opposite to an orthostatic response. The vagal nerve actually will suppress the heart rate when the brain is actually trying to protect itself from high pressure and high flow. Is the exact opposite of when someone actually has a low blood pressure, where they actually have stimulus for a higher heart rate. So something's a little concerning here with the low respiratory rate. The meds for intubation all have to do with kind of that specific patient's condition, because obviously, if you're intubating someone who's seizing, has hypoglycemia and septic shock, and they have a lower blood pressure, then you're going to tailor your medications to the hemodynamics of that patient. If the blood pressure is elevated, then actually, you could say, well, fine, I can actually use propofol on this patient because my blood pressure is so high that I actually am looking to maybe bring it down a little bit. So the induction agent, I think, is still specific to the patient indication for the underlying condition. The paralytic is one or the other. Obviously, it's going to be either a depolarizing or a non-depolarizing. So succinylcholine in this patient is going to be a fast onset and fast offset, which is good so that clinically you can see if the patient is seizing or not seizing. Again, without having continuous EEG on this patient, your endpoint for your medications is whether the person is still having a convulsion, which technically is what we're talking about, right? Without actually being able to diagnose cerebral activity to say it's a seizure, we're looking at the clinical convulsion, and either they're still convulsing or they're not convulsing. And if you've given a long-acting paralytic and now you can't see them having clinical convulsions or not, then you're in the dark unless you actually can get them on EEG, or you can get Sugamidex and reverse them. So I would keep that in mind, or whether you're actually going to use a short-acting or a longer-acting, or whether you're going to then reverse the long-acting. So I think that's the key points for this patient.
Yeah, and that's a fantastic point, right? Because that, continuous EEG monitoring is not really available except in like larger centers, at least in my experience. So yeah, you put that patient, you give them rocuronium, or probably not vecuronium, but even if you give them rock, you're just not going to really know, and then you're just going to be guessing. And so I think some of the stuff that Mac talked about earlier also, if the patient does have some type of cause like hyponatremia, and maybe it takes a while to get labs back if you don't have the ability to do that through your ABG or VBG, right? And, it might take 45 minutes to an hour to get stuff back, and all that wouldn't be treated. Maybe that patient is still seizing while they're paralyzed. So let's now find out what the actual clinician did in this situation. So they gave another 2 of Ativan. The first was given by MS, so now they have a total of 4. They did a bunch of labs, and Mac, they did do a BMP, of course they did that, and bedside glucose, which was 86. They still had seizures, so now they gave a 3rd dose of lorazepam, and they also gave a gram of Keppra. However, the patient became hypoxic, decision was made to intubate, and so a short time after that, they gave 20 of etomidate, and Joe, look at that, they gave Sux 100 milligrams intubated with a direct laryngoscopy, interestingly, with the 8O ET tube. Intubation was uneventful. So now let's go to the next point. We have our patient intubated. And so, Joe, why don't we just start back with you again? What's the best approach for post-intubation sedation and analgesia?
So again, specifically for this case, is that you'd like to say, well, can I get double duty? Can I actually use what I'm going to use to keep this patient comfortable and obviously calm, because now we're going for imaging? Will that also be a medication for my seizures, right, to help the status epilepticus? So, and then the third thing is with elevated blood pressure. So I think propofol would be probably what I would choose right off the bat for this patient, because I know I can actually use it. It's going to be safe. I can stop it quickly if I want to get a neurologic exam. If it does turn out that this patient does have a subarachnoid and a neurosurgeon wants to come in and get an exam on the patient, I can stop the propofol and have an unmasked exam pretty quickly. It will obviously it'll be very good for our seizures. And then the third thing is, the side effect of it is it's going to cause some lowering of the blood pressure, but in this patient, that's actually going to be fine, because I'm actually what I'm looking for. I would again contrast that with someone like with sepsis or hypoglycemia, meningitis, where we actually had low blood pressure, and I would say, well, for that patient, I'd probably be using something like a lower dose of a fentanyl or low dose. Really low dose propofol, but if it's really sepsis, I probably would stay away from propofol. It's just going to be too much of a vasodilatory, agent. And then I would probably think about using ketamine for the sedation as a bonus of having it hemodynamically stable and with some anti-seizure, anti-MDMA receptors. So adding on to whatever else we've given for our seizures. So for this patient, probably I'd start out with propofol.
Okay, awesome. And so can you give us, would you do a bolus and a drip? And how much would you give specifically?
I probably wouldn't bolus if I was starting it shortly after the RSI meds,
Okay.
but I would start it at probably at least, again, enough that I would think that I could get him through the imaging, because it seems like that's our first endpoint here, is that we got the patient intubated to get them for the part of the differential. Because I agree with everyone else on the panel that we need to rule out some pretty important things that are our decision tree for where we're going here, whether it's, again, an ICH or, again, ischemic stroke, cerebral edema, press already, versus a subarachnoid, with need for intervention for maybe a ventriculostomy and/or coiling. So I think I would start out with probably maybe not a bolus, but start out with a more generous ongoing rate until we got the patient imaged, and then kind of control from there.
Okay, so Karina, we'll put you back in the footsteps and just talk about that blood pressure itself. Do you want to start lowering that blood pressure now? I mean, we can get a CAT scan in like 5 minutes, right? Assuming we have the patient intubated and they're stable-ish in the sense that now they're paralyzed and sedated, say, that they are in that situation, would you start lowering the blood pressure now, or do you want to just sort of see what the CAT scan shows first?
I think that's a really good question. It's a tough question, but I would say that with how quickly we can get a CAT scan done these days, my answer is that I typically wait. I think that sort of your therapeutic target and choice of antihypertensive agent should really be tailored to the specific underlying pathology. So without a definitive diagnosis, empirically starting them on antihypertensive medications when you've just started them on propofol, which could have, some patholysis effect, you risk overcorrecting them, leading to iatrogenic hypotension. And so I think I'd be a little bit more careful. There's a common perception that, rapid blood pressure reduction is urgently needed, sort of that every minute counts, kind of like the way we think of antibiotics in sepsis or thrombolytics in stroke. But I don't think that this notion holds up with current evidence. So I would say that I would wait, because I like to know exactly what I'm treating before I start my hypertensive agent.
Gotcha. And the old days, Scott Weingart corrected me on this. I gave him the quote about like attention pneumothorax, and I said, it's a mark of shame on the doctor who orders a chest X-ray who shows attention pneumothorax. He's like, Mike, we just do those bedside now. I was like, oh yeah, that's true. That expression probably needs to be retired from, dating myself when we put the board up and it actually was a wet read because it was dripping still, the developer under your hands. So, we can get the CAT scan done so quickly, and you're right. The patient's already probably been here for a period of time with the different things that have been done, waiting just a few extra minutes. I sort of feel in the same way that'd be the case. So Mac, if we do, of course, we are going to try to lower that blood pressure, right? But what is your sort of goal in a patient? And I'm not talking about a patient with a head bleed, but just like in general, if we think this could be a hypertensive emergency manifesting as seizures, encephalopathy, or maybe press, and we'll talk about that. But what is a blood pressure goal? What percentage decrease are you thinking about, just sort of in all comers, that you want to shoot for?
Yeah. One thing I did want to say, I want to piggyback off of Dr. Reyner. She had a really good point there. I just feel like, people freak out about all these things, but like acute process generally need a little more acute care, but you have time to think. If it's, hypertensive disease, you have a little more time to think on this. I like to, when I explain this to my residents, kind of like a dam. When the water is overflowing, you take a little bit of the water off and things will kind of settle, but you still have time to think before the dam's over, But in any case, general
Don't gamble
goal,
except in Vegas.
yeah, or if you're on like a specific casino ground, not at a hospital,
Okay.
no gambling machines at a hospital. So blood pressure goal, generally just a nice round number is 20%. If you can remember 20% systolic, that's pretty much generally going to be your go-to for majority of things. There's specific blood pressure ranges that they have, like we talked about earlier, preeclampsia, subarachnoid, comparative to ischemic strokes, aortic dissections. They all have their own different numbers that you want to go by. But if it's just a tried and true hypertensive emergency with like end organ ischemia for like a bad AKI or something like that, 20% drop in the first hour, not more than that. And I also like to say if it's a little bit under, it's okay. Like you don't have to do it right now. gently do it. Strokes are much worse than like an extra half an hour of a little bit of kidney damage.
Gotcha. All right. So we are ready for the question that was asked earlier. And Curtis, again, thanks for this question. This is an article by Anderson et al. And I, when this article came out, sent this to all of our hospitalists. I'm sure they super appreciated it. But you want to go ahead and summarize that for us, Dan?
Yeah, for sure. So this was a really interesting article published in 2023 in JAMA, which was a retrospective cohort study looking at the effects of intensive blood pressure management in hospitalized adults over the age of 65. So the study had 66,000 patients, and it was looking for, they were hospitalized with non-cardiac conditions who experienced elevated blood pressure within 48 hours of admission. 21% of that 66,000 received intensive antihypertensive therapy while inpatient, whether IV or oral, and that was defined as new hypertensive medications that they weren't taking prior to admission. The primary outcome was a composite of inpatient mortality, ICU transfer, stroke, AKI, BNP, and troponin elevation. And the study found that the patients who received intensive blood pressure treatment had a higher risk of experiencing each component of that composite besides stroke and mortality. And these findings were consistent across all the subgroups. The risk was even greater with patients who received IV antihypertensive therapy, and the patients receiving the intensive treatment were also less likely to be discharged home. So I think this study, was really interesting because it kind of tells me that we really should not be aggressively treating these inpatient elevated blood pressures without signs of end organ damage. And it was a large study, 66,000 patients in a big name journal. So I think it's really something that we should pay attention to.
Awesome. Thank you so much for that. And I encourage folks to read this. It's quite interesting. It's inpatient based, but obviously there's still some relevance for all of us too. Okay, so what happens with the patient? What did the actual provider do? They gave now 4 milligrams of Ativan post-intubation and was taken to CT, just like Karina, you had thought that you would do also. And they did not see any large intracranial hemorrhage, is how they documented it. Labs started coming in, was not hyponatremic, 147, was a little bit hyperkalemic, but not any significant amount, and was acidotic, and at least they had some amount of renal failure, whether it's acute renal failure or not, hard to say, but creat was 4.8, and their total CK was 4,300. Blood pressure is rechecked, and boy, it has not budged. And so I can sort of scroll back real briefly here. They came in at 11:02, and now here it is at 12:44, so about an hour 40 later, and the blood pressure is still exactly the same, and they're starting the patient on some Keppra, some propofol like Joe had recommended, and then the brain CT is negative. So Joe, we get at our third decision point here. This has always been confusing for me, but PRES syndrome, hypertensive emergency, is it important for us to differentiate those two as bedside ER clinicians, or can we sort of think of them as similar type of entities and treat them in similar ways?
Yes, it'd be okay to treat them in a similar way. So hypertensive emergency, obviously for end organ damage for the brain, we were talking about a hypertensive encephalopathy. And so that really is, PRES is a large umbrella of categories of things that are affecting the brain with basically vasogenic edema, particularly in the posterior compartment. It seems to be more vulnerable to that because of the way the brain's innervated. But PRES also would include things like the panelists have mentioned with eclampsia, HUS, TTP, medication-induced emergencies like some of the immunosuppressive, some of the chemotherapeutic agents. So there's a lot of things that can cause PRES, including severe hypertensive or hypertensive encephalopathy. So for this, if you wrote it in your chart, hypertensive emergency, hypertensive encephalopathy, PRES, you'd be correct to say all of that.
Okay, awesome. And here's an article that is a review article, but I thought that was a pretty well done review article that just came out a couple years ago in New England Journal of Medicine about PRES, and this is by Geo Caden. So if folks have any interested, or you could email me and I can send that to you. So Karina, how about fluids? It always seems like those acute renal failure patients, I don't know that's always this, but it always seems like a good liter bolus is not the worst idea in the world. I know I would get pushback from nurses as far as giving patients fluids who is hypertensive, but it's not quite that simple.
No, I think it's a little bit more nuanced than that.
Yeah.
And so, for me, for a hypertensive urgency, it's not always volume loss. I think understanding sort of the history is always super important, and understanding the pathophysiology. Oftentimes it's just unregulated vasoconstriction and a high systemic vascular resistance that's causing this end organ damage. But, in some cases, these patients are so symptomatic that they're vomiting. And so they do have some intravascular volume loss. So it's not I think it's okay to give those patients fluids. But oftentimes, from my perspective, the more important thing is to really tightly control that blood pressure when you have a patient with a hypertensive emergency. But again, at some select patients with volume depletion, you can sort of figure that out with your history. I think fluids are okay in that scenario.
So a fish or cut bait moment, are you going to give the patient some fluids? And if so, how much? Are you going to wait?
I think it's reasonable to do, just start with a liter of LR in this case. I don't think it's going to be necessarily harmful.
Okay. All right, Joe, you good with that also?
I probably would give less the amount. I probably wouldn't write for a 1 liter up front. I would probably do it in smaller aliquots.
Okay.
So that if I needed to, because the real complication is that when you do give that person, again, a direct acting vasodilator, because I agree with what Karina saying, remember 99.99% of people that have hypertension do not have high cardiac outputs. They have high SVR. So they actually do not need their cardiac output reduced. They need their vascular tension reduced. But if their volume is anything but normal at the time and you give them a direct acting vasodilator, the blood pressure could plummet. So you could overshoot drastically. So that's why it's important to make sure that you're establishing vascular volume and a normal cardiac output in those patients. And that can be a difficult thing to evaluate at the bedside, except if you already have the history of the person actually having poor PO intake or extra urine losses or sweating or vomiting, so forth. So I would probably start out with a small bolus, but ready to give further if their blood pressure reacted in a way much more precipitously than I thought they would based on the medication that we had given.
Got it. So it sounds like you agree that it's a good idea to give fluids, maybe just a little bit of a different amount. So Dan, would you be good with the diagnosis of hypertensive emergency at this point? You gave us a great differential before, but it turns out the patient doesn't have hyponatremia or a brain bleed or all these different things. Are you good with that as a diagnosis?
I think, kind of as mentioned, I think the diagnosis of PRESS would be probably most appropriate here. I mean, we have a patient, he has headaches, seizures, altered mental status, no signs of infection in the presence of a severely elevated blood pressure. I think posterior reversible encephalopathy syndrome, or PRESS, would be appropriate here. And then, as kind of mentioned, it's often triggered by hypertension, but also seen in things like kidney failure, eclampsia, or preeclampsia, immunosuppressive medications. And then seizure is seen about 2/3 of the time in PRESS, and it's the initial presentation about half the time.
Awesome. So we have a twist that's going to happen in this case here. So do stick around. Mac, what are you thinking? Your approach now to antihypertensive therapy, we have the patient still 228/142. There's nothing else really to do as far as reversible things. He's already intubated. What are you thinking as far as antihypertensive therapy at this point?
So first and foremost, I'd see kind of what the propofol is at, because if I can just do the one and done with the propofol and drop it enough.
Mm-hmm.
Granted, if it's already at my institution maxed out at like 65, so I would stop there so I don't make a bunch of people mad when my orders are all sorts of janky. I have access to nicardipine. Other institutions are using clevidipine, and clevidipine I feel like is a better call here because it has a faster, like the half-life is 5 to 8 minutes, and when you compare that with cardine, all of a sudden it's upwards of I think it's like 8 hours or something like that. It's a really long time, and when you have something this critical and this acute and this much chance of like risk when you start the medication, you really want to be able to turn it off. So like esmolol, I feel like it's such a better agent comparative with metoprolol if you really want to control the heart rate in someone with like aortic dissection or thyroid storm or that kind of thing. So the fast on, fast off. I would make a mention as well, like magnesium. I was reading about magnesium for hypertensive emergencies, not just in preeclamptic patients or clamptic patients. And then, and obviously your bad heart failure patients, always keep a lookout for your nitros.
Okay. So what happens? What did they do with this patient? They gave him some calcium gluconate, I'm guessing because of that hyperkalemia, although probably not a huge risk of arrhythmia of 6.3, but if there's EKG changes, of course, as well as sodium bicarb, some insulin and dextrose. So they're treating the hyperkalemia. They consult nephrology, who wants some bicarb, and I think his serum bicarb was 12, if I'm remembering correctly. And they gave, as it turns out, a liter of fluid, but they gave it over 8 hours. It looks like 125 cc's per hour. A lot of ways to skin a cat, right? So they had a presumptive diagnosis of hypertensive encephalopathy. Remember, the patient came in, I believe it was at 11:02 p.m., and so now it's about almost 2 in the morning. So they've been there, just under 3 hours. They started the patient on nicardipine, as you mentioned, Mac, and paged neurology, and they started at 5 milligrams per hour, and they started increasing the dose. However, I will just show you the blood pressure log. So these were the initial blood pressures. You saw those on the charts. The one at 0028 was the one that I put on that most recent thing as far as decision point on what the actual clinician did. I think it was 228 over 142. But take a look between 205 and 224. All of a sudden, and then down to 226, you have over 100 millimeter mercury decrease in the systolic blood pressure. So a drastic decrease in the blood pressure. So let's go to our last decision point. We'll have to do this one a little bit more quickly. And just going to start with you, Joe. I'm not saying this is right or wrong, but I'm saying it happened, right? Now we recognize that it has happened. What do we do when all of a sudden we realize that we've drastically overshot our blood pressure goal?
So part of the decision is this patient's symptomatic or not symptomatic at the time. Doesn't mean you're not going to treat both, but obviously the impetus to treat rapidly is if this person is either lightheaded or maybe has onset of neurologic symptoms at the time. Then you're going to need to be very rapid and more aggressive. Either way, you need to stop the antihypertensive infusion if it's ongoing, and stop any sedatives if you think that's contributing. So if this patient was on Cardine and propofol, I would pause both of them immediately. I would think about if the blood pressure wasn't responding pretty quickly, there's a reasonable antidote for Cardine, which is again IV calcium because it's a calcium channel blocker. So that's relatively simple to replace that. And then if the patient also was having some symptoms, I would immediately put their head of the bed down to maintain cerebral perfusion. So that's quite an easy thing to do, lowering the head, legs up, very simple things. And I would reserve a fluid bolus and or a pressor for if those things were not helping, if I then felt like I needed to continue onwards. But I would do kind of a sequence of less aggressive, less invasive things, stopping the drips, stopping the sedation, potentially head of bed down, calcium reversal.
So I guess, Karina, Mac, it's sort of a similar question as to one that Joe just said, but throw in some of your insights. There's a lot of different things that could be done in the situation, and then there's sometimes push dose pressures for other reasons too. Karina, why don't you start? What are some of your thoughts at this point? Where we're going to go, or maybe even some other thoughts on how we could have prevented it from going down so quickly?
Really don't have much to add because that was so well stated, but I'll just say, I always just look at the patient. I think sometimes we forget, turn off what's on, hold it, and then push dose pressors are a great bridge. They're not a long-term solution, but the goal is just to restore perfusion quickly, dropping the head of the bed. Those are all great strategies. And I think the bigger learning opportunity here that I try to reinforce to my residents is that when you order a titratable medication, you need to very clearly put the parameters that you want that medication titrated to, because the onus is on us to do that. And if we don't, the nurse might think, oh, I should get this patient down to 120. That seems like a reasonable goal. So I think that's really the big teaching point here, is making sure that we're clear in our communication with the nurses who are going to be administering these medications.
Mac, some thoughts, then we'll find out what happened to the patient and we'll wrap things up.
Yeah, I think push dose pressors are great as like a try and reverse what's happening. But also if you can precipitate something happening in the future, like intubate someone that's like near septic shock, they're probably going to drop down. Always just have that on hand. But I think Dr. Reyner and Dr. Shiber absolutely killed it.
They're hard acts to follow, right?
I'll just leave.
All right. So what happened with the patient? Profound drop in blood pressure, and they had the propofol as well as the nicardipine. The nurse noted the decline, stopped all the medications immediately before informing the doctor. So it's good. They gave 2 liters of fluid, interestingly. Didn't really mention the head of the bed thing. And Joe, that's like, you're right. Simplest, easiest, fastest thing you could possibly do, and there's no way that you aren't increasing perfusion of the brain if you do that, right? And you can look, I mean, it took a while until it got up, so even at the 169, we're nowhere near that number, the 20%, that, and the same thing I think in my head, that Mac had talked about. Patients transferred to the ICU, the patient had a watershed infarct, and they unfortunately ended up in extended care facility because they weren't able to be weaned for mechanical ventilation, and underwent a trach and a peg placement, and had prolonged ventilator management. So really a very horrible outcome. And absolutely, before we get some of the thoughts from everybody, I'll put the QR code up for folks to get their CME. Absolutely, you know, this could happen in different ERs, especially in busy ERs. And we're looking at one patient, you know, bunch of people on the call and the panelists here, we're all looking together at one patient, whereas normally it's us with whatever, 10, 15, 20, whatever patients that we're, you know, caring for at the same time. So one thing that I would take away is if you have a patient on a medication that does have the potential to really drastically decrease things, and again, not saying anything wrong with them, but man, got to be super vigilant about watching that medicine and making sure, again, like Karina said, the communication with the nurses is very, very spot on, that they know exactly what your goal is. So here's the QR code for the CME, and I'm going to come back to this in 2 seconds here. So in case you don't have your phones handy or out real quick, Mac, and then Dan, Karina, and Joe, I'm just going to have everybody give like a 30 or 45 second, what would you like folks to take away at the end of this hour of their lives they have graciously given to us?
I think the most important thing is just, you know, if you have a chance to care for someone earlier than later. I'm at a big county institution, so I do a lot of primary care as part of my ER job as it is. Second piece is also just be super careful and be super duper watchful of your patients. Every little thing can, you know, every little rock can cover a little snake or a bug. So you got to be safe with everything you do.
All right, excellent. All right, Dan, what are the takeaway points you'd like folks to leave with?
For me, you know, really without mentioning anything that hasn't already been said, I think it's just kind of that article with aggressive treatment of inpatient blood pressure, just something that's very common, and, you know, article is pretty recent that came out. So I think that's something we should really keep an eye on.
Nice, love it. All right, Karina, what are your thoughts?
Sometimes it's better to do nothing, and sometimes it's better just to educate the patient. And so if a patient's MAP, you know, is elevated but not in that severe range where you have, you know, dysregulation of or cerebral autoregulation dysfunction, then the more important thing is to counsel the patient, because we've all seen cases of iatrogenic hypotension from giving patients a big slug of labetalol and discharging them home, or giving them a big dose of hydralazine. And often, if you're treating yourself more than the patient, then you need to take a step back and maybe find a different approach.
Awesome. Joe, take home points.
Yeah, I agree with Karina. Talking with the patient and educating them and making sure they understand the process of what's happening with their body, and not just that you don't want to treat them because you're not interested in it, because that's the message that they'll get when they hear, well, you know, we're not going to do anything about it. They kind of feel like you're withholding. But for them to understand why you're doing what you're doing, it takes time and energy, but that's the way to do it. And I think should be very careful having someone be in and out of the ED within 30 minutes. They should be sometimes, you know, work note, you know, but someone wants you to look at a rash or something very simple. But I think for significant things, you should be very careful having people in and out in that quickly of a time, and not again converting them from a snapshot to actually a longer duration and time, so you can show that you know that the person is doing okay.
I love that saying. Can you share with us again, Joe, what that saying was? The snapshot saying?
Either convert a snapshot to a slideshow.
I love it. That
So
that
that's
is
just one
perfect.
thing.
I'm gonna start saying that. I'm gonna give you credit though. I promise. A snapshot to a slideshow. That's fantastic. All right. So for our next case is Monday, June 2nd. This will be our last case of our sort of season. We take our summer break, and then it's always, Labor Day in September. So we resume on the first Monday in October. We only have 2 more chapters left in the Critical Care Bounce Back book, and that will be the first Monday in October, first Monday in November. And then we're just going to sort of have to figure out where we're going from there, as far as, because I have to say, on my own personal level, I've learned so much from the fantastic folks that have been here. And this panel here today was absolutely fantastic. So this is the interesting case we're going to be talking about on June 2nd. The register to link is on the website, embouncebacks.com. So emergencymedicine.bouncebacks.com. Here's the QR code to register for the one June 2nd. And thank you all so much for sharing the hour of your life with us. I hope we've been true to you. And mostly thank you again so much to our fantastic panelists. Anybody that wants to watch this, it will be posted by probably later tomorrow morning, tomorrow early afternoon, to the EM Bouncebacks website, as all of the Critical Care Bouncebacks are posted. And I hope everyone has a great rest of your night. Take care, everyone.
Thanks, Michael.
Thanks again, guys.
Thanks for having me, man. Always a pleasure to see you.
Thanks.
See you guys.
You have definitely had too much Weinstock time lately. Dash, haha, exclamation point. It was so fantastic to have you as a part, and I will definitely do that. Great. Hopefully some of your residents will get to see your expertise and insights. Thank you, everyone, so much. Fantastic session. And if I could channel all of the great knowledge in your brains, I would be so happy, exclamation point. It was really an honor. Just saw the post about Joe being your attending. Period. So funny. Well, sure, Kama. I didn't even realize you were a part. Period. Yes, what a amazing case. And the panelists were such incredible experts, exclamation point. But super tragic case, ... Feedback is that you are awesome, and just never say no, exclamation point. I thought you did a great job. It was an honor to have you. And in the next few days, we will set up some times to do some recording for UC Max. This stuff is so fun and just keeps me super energized. Yes, Kama. The issue is the nicardipine can just cause such a precipitous drop, and I tried to be pretty clear that I was not throwing any stones at anyone on this case. When I have patients on that medicine, I am in the room pretty frequently and having also very frequent discussions with the nurse. And perhaps that was happening in this case also. Sounds good, comma, was a great conference. Period. One more than summer break, exclamation point. Agreed, period. Like I said, I'm a big minimizer when it comes to elevated blood pressures, but 135 diastolic would definitely get my attention, especially on the repeat, ... Is the game still going on? Should I come over, question mark? Love it, comma, exactly what we had envisioned, exclamation point. Steve, do you have any edits to add, question mark? I only watched it once and will watch again, but I thought it was fantastic, period. Jamie, the only thing now that I am just talking into my phone, haha, comma, is do you think we should cut off the first 6 or 7 seconds when I say we are the Big Rock and Blues Band, or is it nice to have that as the beginning, question mark? Not sure 7 seconds would make a big difference anyway. Bum 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 bum. By the way, the case next month is a super good one, period. Turns out that all cases of patients with fever do not have it because of a infection, dot, dot, dot. I just got back from Dallas this morning, and just about all conferences that I speak at or lectures, grand rounds that I give, I always talk about moving people from standard of care to excellence in care, period. There are some egregiously bad cases, but those aren't the ones I present, period. The ones I think are most interesting are where we can put ourselves in the footsteps and say that we might have handled things the same way. And it's only by saying that do we have the opportunity to improve. Comma, myself included, exclamation point. Oh yeah, great idea. Good. Jamie, would you mind doing that? And just put on something like the Big Rock and Blues Band, and then my phone number and my email. It should be super easy to do. Or would it be better to direct them to the website, question mark?
That is a very interesting question.
terrifying history. Facts you didn't learn in school. The last one will shock you. Margaret Pole, the Countess of Salisbury, was executed on May 27, 1541, for supporting Roman Catholicism and conspiring against the king. It took the inexperienced executioner 11 chops at Pole's neck, head, and back before the 67-year-old was pronounced dead. The Romans used a communal sponge on a stick to wipe themselves after defecating. This item was usually dipped in a bucket filled with water or vinegar in between uses to sanitize it. In 1531, Richard Roos poisoned a bunch of people dining at the home.
Cool. I'm Weinstock.
Hey.